Okay, hi everyone. My name is D.GONDEK. I'm working for Anna Freud Center, which is a charity working with kids. Mostly we're doing research about service improvement. We're part of University College of London. I'm going to present the results of a systematic review which we conducted, which looked into feedback from outcome measures and its impact on treatment effectiveness, treatment efficacy and efficiency, and collaborative practice. So there's been a recent push for evidence-based and person-centered approach to treatment, especially in the UK and I guess probably in the US. I'm not sure about other European countries. So it's more and more often the treatment is more focused rather on illness, on a person. Therefore, the clinicians are seeking views and preferences of patients in a different ways. One of the way how to make sure that the treatment is evidence-based and it's informed by what patients actually want to achieve for the treatment is to use feedback from outcome measures. What I mean by outcome measures is any kind of standardized, validated questionnaires which aim to provide information on mental health status, symptom status, unmet needs. Quite often, these measures, they also are combined with some sort of cutoff score or clinical significance methodology. So the score of the measure will indicate if the patient is progressing as expected, or some changes might be needed in the treatment, or they might show that it might be a time for discharge from the treatment. The way feedback works, from what I understand, it's quite simple. This feedback intervention theory and self-regulation theory suggests that a patient, when the patient or clinician receives the score from the feedback measure, from the outcome measure, then they get involved in some sort of comparison process between the actual progress and the expected progress, and that may trigger a cognitive dissonance and some self-regulation actions. So they just might try to do something about decreasing this discrepancy between what's desired and what's actually happening. So, looking into literature, feedback from outcome measures has been shown to improve treatment effectiveness. So measured as the symptoms or just kind of a patient's functioning, and especially for those who are not progressing as expected, and also when it was moderated by feedback being given to both clinician and patients rather than just clinician. In terms of efficiency, what do I mean by efficiency is simply the number of sessions needed to achieve the desired outcome of the treatment. It was shown by one meta-analysis conducted in 2003 that it did decrease the number of sessions needed. It actually decreased the number of sessions needed mostly for patients who are on track, because it's indicated earlier on that the patients might be ready to be discharged. However, it did increase the number of sessions for patients who are not on track. Again, it just indicated that they might need some more sessions to achieve desired outcome. However, in the meta-analysis, altogether, it showed that it increased the number of sessions needed in the total number. Also, it's been hypothesized that feedback should improve collaborative practice, so it should lead to greater treatment satisfaction, patient autonomy, self-confidence, adherence to treatments, or therapeutic alliance. However, there's been no review before which would look at this outcome. So the main research aims of the review was to look at treatment effectiveness with a particular focus on the on-track patients in the feedback condition versus not on-track patients in the feedback condition. Treatment effectiveness as moderated by feedback recipient. Treatment efficiency with, again, particular focus on this distinction between not on-track patients and on-track patients, and collaborative practice. So we've searched most of the major databases. We did conduct a search in grey literature, so in all unpublished literature. We look at also if there's been any registered trials at the time of the review. There have been one or two. However, when I requested results, of course, I wasn't able to get them because the studies haven't been published yet, even though I think they had the results available. The way we designed the search, we split it into concepts: mental health. We mapped all the terms related to mental illness or symptomology according to DSM-4 and 5, ICD-10. The search was conducted in abstract titles. We also used the subject headings, the mesh terms, which explores the wider terms into kind of narrower terms to make sure that all the range of terms are captured within the concept. The second concept was feedback. Because it's still such an undefined and broad concept, we used a lot of different terms such as outcome evaluation, outcome management, routine outcome monitoring, and these terms were identified through scanning the relevant literature. As usual, we combined the concept through OR and AND, Boolean operator, and references were managed in Excel spreadsheet and EndNote. Very quickly, inclusion criteria. We only look at studies published in English, which use control designs. So we would compare feedback interventions, so a group where the treatment as usual was supported by feedback, and that was compared to a control group where patients were receiving just a treatment as usual. We also looked at both randomized and non-randomized trials. We were only interested in mental health settings, specialized mental health settings, which were designed to treat mental health disorders, so for example, not necessarily community settings. We only look at feedback which was based on standardized and validated measures, and it was used at least one. It wasn't just assessment, but it was specifically used for feedback purpose. So we didn't include studies where the measurement would only take time at the assessment, and so then it wasn't the kind of treatment progress wasn't captured through the measure. Very quickly, flow diagram. We started with over 5,000 studies through a very long process of screening abstracts and titles. If you've done systematic reviews, probably you know what I'm talking about. Very long process. Through assessment of full text, we ended up with 34 studies, 34 trials, which actually 34 publications, which corresponded to 32 studies. Okay, very quickly, study characteristics. Most studies were conducted in States, a couple in Europe. Most of them were randomized. The design was randomized. There were quite a few unpublished studies, most PhD dissertations. Most of them were conducted in outpatient settings. Very few in adolescents. Actually, initially this review was supposed to be with young people because that's the work we're doing, and we found only 2 studies. So it's still mostly used in adults population. And unit of randomizations, in most cases, were patients. So feedback characteristics. So the outcome measures which are most commonly used was outcome questionnaire 45, which you might know. I think it's quite popular. It was created by Lampert and colleagues at the university in Utah. It's 3 subscales looking at symptoms, interpersonal relationships, and kind of functioning, like daily life functioning. The other most popular outcome measure was session outcome rating scale, rating scale and outcome rating scale. So the session rating scale purely looks at therapeutic alliance and kind of therapeutic relationship, whereas the outcome rating scale is very similar to outcome questionnaire 45, looks at functioning, symptoms. The second one, the outcome rating scales are very brief. It's only one question, 10 centimeters line, and you just put a cross somewhere on the line between to indicate your progress. So from the left pole, which is 0 to, and then you just measure the distance between the left pole and where the cross is, and you compare the kind of progress on it. Other instruments include, we're looking at psychosocial symptoms as well, functioning, well-being, quality of life, needs assessment, or therapeutic processes, so like, again, therapeutic alliance. Most cases, actually in 15 studies out of 34, or the feedback was provided to clinicians and patients, and in 12 of them only to clinicians only. In most cases, it was administered session by session. In 2 studies, it was administered only twice, and in 2 studies, only once. However, I should mention that in the studies where it was administered only once, the feedback received was much more comprehensive. So it had a list of potential interventions. It wasn't just the treatment, progression of the treatment, but also had it provided much more comprehensive information. In studies where it was administered session by session, most of the time it would include the feedback would include a progress graph with plotted scores session by session, just to show the fluctuation of the symptoms and other measures. Usually it would be supported with a sentence or two what it actually means. So the pattern in the data, what if it means that the patient is progressing as expected, or some change might be needed. And a few studies, as I mentioned, was much more comprehensive with a decision tree or a list of suitable interventions. Okay, so results. So what we did was very simple. We just look at the proportion of studies where the feedback intervention had a greater improvement than the control intervention. And in 56% of studies, on at least one outcome measure, I should mention that as well, because some studies use more than one outcome measure, and quite often the treatment would have effect only on one outcome measure, but not on others. And in 56%, there was improvement. The feedback group did better, or at least one outcome measure than control group in the total sample. However, when we look at patients who are not on track, in 73% of studies, feedback group did better, which we liked. We liked this finding because we are quite strong proponents of feedback, so that was good to see. In terms of treatment, moderators of treatment effects, if the feedback was provided to clinicians only in 12 studies, in only 5 of them, feedback did better than control group. However, when it was provided in 14 studies to both clinicians, patients, and 64% studies did better when it was provided to both clinician and patient. There were 4 studies where there was a direct comparison of these two groups, so they would include additional study arm where feedback would be provided to both patient and clinician. In one of them would be a clinician only, and also the control group. And in 2 studies, patient and clinician did better than clinicians only, and in 2 studies there was no difference. In terms of treatment efficiency, in 2 studies, in general, in the total sample, feedback did reduce number of sessions needed. In 6 studies there was no difference, and in 2 studies, again, control, the number of sessions needed were greater in feedback. So the treatment efficiency was lower in control. For not on track patients, as expected, participants in the control group received less sessions, so you could argue that the treatment was less efficient. However, it's not really a fair argument because they did better in terms of their improvement. So you could argue that what it shows is simply a better allocation of resources. So patients who were on track had less sessions, and patients who were not on track had more sessions, but in general, the feedback did improve the treatment effectiveness, maybe not necessarily the overall number of sessions. However, if we looked only on track patients, in 2 studies there was no difference in number of sessions between feedback and control. So maybe it will be picked up on the meta-analysis like previously, but not in looking at it this way. In terms of collaborative practice, unfortunately, we didn't find that feedback necessarily led to a better collaborative practice between the clinician and the patient. When feedback group did better than control group in terms of collaborative practice outcomes, it was mostly from one study. Overall, we didn't see better therapeutic alliance, for example, or patient satisfaction when the feedback was used. So very quick conclusions. Feedback does seem to be beneficial in terms of effectiveness, especially for non-track-on patients, which is in line with the theories. It makes sense that if you're not on track and you have evidence that you're not on track, both you and your clinician try to do something about it more actively than when you don't have this information, when it's more based on just your own kind of feeling. Seems it's more effective when it's provided both to clinicians and patients, maybe through a better relationship. However, there's no evidence for it. more sessions are needed for not on track patients. Not on track patients are more likely to get more sessions due to feedback. Not on track patients are more likely to probably get less sessions, which I mentioned before. So it's probably a better allocation of resources. And there is some effect on collaborative practice. However, the evidence is too inconclusive. There were some limitations to our study. So we didn't do a meta-analysis because the studies were so different in terms of design, the tools used. And nearly half of the studies were underpowered and had quite high attrition. Intention to treat was rarely conducted. It was more common to use just complete data. And trials were quite often poorly described. So it was difficult to judge if the process of randomization, allocation, or blinding was done properly. And most of the studies were conducted in adult population. So future research probably should include higher sample sizes, should probably look into what actually makes feedback effective, what are the moderators of feedback, and if it causes a burden on the resources. And an update will be needed very soon because since we published our review, there have been already, I think, 3 studies published looking at this area. So yeah, feedback can help. It doesn't hurt. It helps patients who are not on track, and it works better when patients are involved. That's everything. Thank you. I don't know if you have any questions. Is anything unclear? Or yeah.
What kind of feedback was given? Did I miss the first slide or something that I don't?
Yeah, I didn't explain it very well because there were so many different examples of feedback used, and it wasn't really our main concern. We were just interested if supporting treatment with outcome measures and using the information from outcome measures in the treatment might result in better effectiveness. But I was expecting that I might get this question, so I prepared an example. So I just took it directly from a paper. This is based on Lampert work, Michael Lampert. I think they are the biggest in the field. So they've got this. I will try to explain as well as I can. However, I'm aware that I might not manage very well. But so they've got based on this baseline score, then they follow the participant. So you can get a score between I think 0 and 30. The cutoff point is 63. If you get more points than 63, it means there's a problem there. If it's less than 63, you are likely not. Probably it's okay. Like you will still start the treatment, but it's going well. So you start somewhere in yellow or red area, which is like indicators of what's going on. And then you can move either from red to yellow to green, or from red to yellow to white. White it means that you are likely to be discharged. So okay, I'm not sure if I'm explaining very well, but
okay. So white means that the person's progressing well and is going to be discharged, and red means they still
is not going to work.
Okay.
So you start with 90, for example. You improve by let's say 15 points. So you are 75. So you are in yellow. So it's going okay, but still you need more sessions. We need to carry on. So you improve again by let's say 25. So you started with I think I said 90. So you are 65. So you are 25. So you are here. So you are in white. So it means that probably you're going to be discharged. So it's all based on kind of very simple color coding. So clinician and that shows the kind of trajectory. So every session this measure is administered. And you look at where you are in terms of the color, and which gives you indication of what you should do if you should try to change something in treatment. What's going well? Let's keep it going. And that's supported. If every color is supported by this one sentence. So for example, white field. If you get the white dot at the session after the session, it just means the client is functioning in the normal range. Consider termination. If you get red feedback, the client is not making the expected level of progress, some changes might be needed. So that's what they come up with.
okay.
And it's all based on validation of the instrument with different populations, clinical population and normal population. So I think that's the most commonly used one. Probably it looks better in terms of the graphics these days because this is from 2001, But that's it. I think the idea of the system is the same.
Thank you.
Don't know if that's... Okay, thank you a lot. Thank you for your attention.